you going?
I'm doing well. How are you?
Good. How's that? You can see that?
Yeah, I can see that. I can see that.
Great.
Okay, great. Let's get started so we can have some time for some questions at the end as well. So Claire, thank you so much for joining us and taking us through the red blood cell exchange for adults. We're looking forward to this session. I'm looking forward to hearing all the information that you're going to be sharing with us. So please go ahead, and we'll have 5 minutes at the end for people to come through and ask you questions.
Great. Thanks, Maisie. And thanks to ASCA for inviting me to present to this inaugural conference. It's very exciting to be a part of this, although I'd rather we were doing it in person, to be fair, maybe next year. All right, so I'm going to talk about the red cell exchange procedure for adult patients, and I'm going to talk a little bit about our experience at Royal Melbourne, because we've been running a program for chronic erythrocytophoresis or red cell exchange for our patients for 20 years as of this year. So it's been very successful for us. So firstly, a red cell exchange is simply just the removal of autologous blood, which is a patient's own blood, and then replacing it with donor packed red blood cells. And it can be done manually, which is the traditional way it was always done, where a unit of blood is venesected, and then a patient is then transfused 1, 2, or 2 units to bring up their hemoglobin. These days, though, we now have machines that are able to do this process much more efficiently, and it's called automatic red cell exchange or erythrocytophoresis, but we tend to just call it red cell exchange. We do have a patient at Royal Melbourne who does have manual exchange still, though, and has done really well with that process, but most of our patients requiring this treatment will go on to automatic exchange. And it is a more efficient removal of the sickle hemoglobin than just a simple transfusion. It does, however, require an apheresis machine, so that's not going to be something that's available to everyone. Preferably it's run through a specialist unit, because there are potential issues that can occur with procedures, so you want people who are familiar with the procedure running that process. And you need a reasonable number of cross-match compatible red cell units to make it worthwhile, and we sort of have a minimum of 4, because less than that really isn't going to be enough to do the procedure adequately. So the rationale for doing red cell exchange is to reduce the circulating sickle hemoglobin concentration and replace it with normal hemoglobin A. And this is to reduce the frequency and severity of vaso-occlusive crises, which we know are very problematic in sickle cell and can lead to end organ damage. So we're trying to reduce the potential for end organ damage in our patients to maintain their health. It also helps to correct anemia. I mean, we call it sickle cell anemia due to the ongoing hemolysis of sickle hemoglobin. And sorry, let's go back again. We find that for patients admitted to hospital, it can reduce the duration of their crises. If we employ early on a sickle red cell exchange, it can also reduce the length of stay in hospital, which is always preferable for our patients. No one ever wants to be there. And subsequently, you can also reduce requirements for opioid analgesia, which is ideal. Gilliams in 2018 did a study to show that red cell exchange actually can have some beneficial effects on blood viscosity, including blood vessel relaxation time, cerebral blood flow velocity, and it can also help to reduce cerebral metabolic stress. And we know that these can be related to stroke, particularly in younger patients. And doing a red cell exchange where you're taking and returning sort of comparable volumes of blood tends to reduce the risk of iron overload, which can occur with simple transfusion. So that's also beneficial. I think I might just jumped ahead, sorry. So indications for red cell exchange probably dependent to some extent on local hospital policy and also access to these kind of procedures. But it is very much indicated for severe consequences of sickle cell, such as stroke, and that can be used to prevent or for someone who's at risk of recurrent stroke. We find that patients who have frequent vaso-occlusive crises requiring hospital admission have poorer outcomes. So if we can avoid those kind of crises occurring, it can be used in an emergence crisis, for example, in acute chest syndrome or in stroke, or where you have evidence of existing end organ damage, such as pulmonary hypertension or silent cortical infarcts demonstrated on MRI. We also find that some patients are unable to tolerate hydroxycarbamide. We recommend all our patients do take Hydrea, even if they are on exchange, but some patients either don't want to take it or unable to take it because of cytopenias associated with the medication. So we find that red cell exchange is particularly helpful in these patients. We use it in pregnancy to reduce the risk of maternal and neonatal mortality, including complications such as intrauterine growth retardation. And we routinely use it preoperatively to reduce sickle levels to avoid adverse events associated, particularly with surgery related to anaesthetic. When we can't do red cell exchange, we might just do a simple transfusion in those situations to bring the hemoglobin up to 100 grams. And again, it can be used to reduce or prevent iron overload. And I will talk specifically about isovolemic hemodilution shortly in a few slides. So our procedural targets, and this is our policy at Royal Melbourne, not saying this is the way it should be done. This is what we've been doing for many years and found it to be effective. And as for guidelines, kind of support these parameters as well. But really for patients who are on a chronic exchange program who are well, we try and maintain them at less than 50% prior to their procedure, their hemoglobin S levels, and try and get their hemoglobin S down to 30% or under post-procedure, and maintain a hematocrit, which is your red cell percentage, around about 30%, give or take 3%. And that's to suppress, we don't want to go too low because otherwise we risk increased hematopoiesis. So we're trying to suppress hematopoiesis so we're not getting more sickle cell being produced. Some of our patients, however, do have relatively high hematocrits. We find our beta-thal, sickle beta-thal patients come in often have a high hematocrit. So we don't let them go much above 36%. Again, it's just because of viscosity can be an issue where you're getting slowing of blood transiting through the small blood vessels, and that puts them at risk of sickling. We are a little more aggressive though in our maintaining our sickle level below 30% in patients who are at risk for primary stroke, and that's a definite indication for that. And we found using those targets that most of our patients were managed really well and have very few crises and even less admission to hospital. I guess it comes down to a balance between treating the disease, but also judicious use of red cell resource, which is precious, and procedural length as well, because the more units that you give, the more side effects patients might experience. So for our treatment parameters, we need to know their height and weight so we can calculate their total blood volume, and the apheresis devices will have hard limits around how fast the procedure will run based on those, and that's to ensure safety and to reduce side effects such as citrate toxicity. We run a relatively low whole blood AC ratio. AC is the anticoagulant, the citrate anticoagulant that we use, so around about 12 to 1, up to 14 to 1. So that means for every 12 mils of blood, we're adding 1 mil of anticoagulant, and that's enough to get the blood through the circuit without creating, again, these problems with citrate toxicity. We need to enter in a pre and post hematocrit because that's our parameters. The machine's based not on hemoglobin levels, but on hematocrit, because that's how the plasma pump on the machine works to control the procedure. And we also need to know roughly what the hematocrit of the replacement fluid is. So we use a generalized guide of about 55%. Again, other hospitals will have their own policies in place for this. And our end of procedure targets are determined by the volume of replacement fluid. So if we've got 1,500 mils of red cells to give back to the patient, then that's our end of procedure once that blood has been transfused. We find procedures take around about 70 minutes for a 6-unit exchange. And our patients receive anywhere between 4 to 6 units at 4 to 6 weekly intervals. A couple of patients might receive 7 units if they are a little harder to control their hemoglobin S concentration. But we found that this is pretty effective in an ongoing chronic exchange program. In an acute situation, you may need to review that and make sure that you're treating the patient adequately. Particularly patients coming in who have not been treated will have much higher starting sickle hemoglobin in their blood. So one of the parameters on the Spectra Optia, which is the machine that we use, and I think probably is in use in Australia, at least in a lot of hospitals, is called the fraction of cells remaining. And this is a calculation based on the patient's own red cells remaining at the end of the procedure. And it can be calculated, it's calculated on the machine, but if you want to calculate it in advance, you can work it out based on the post-procedure percentage of hemoglobin S that you want, divide that by their pre-procedure hemoglobin S and you multiply that by 100. So generally it's around about 50% for a 6-unit exchange. So if they're starting off with a 50% hemoglobin S concentration at the beginning of the procedure, you will know that by the end of the procedure, their hemoglobin S will be about 25%, which is within our parameters that we like. So your fraction of cells remaining will increases with exchange volume, but we find that the law of diminishing returns applies in this situation, in that if you're using more donor units to get your fraction of cells or your post-hemoglobin S lower, you are going to be ending up removing a significant amount of donor red cells into the waste bag as well, which is something we don't really want to occur too much. Again, trying to make the best use of our donor products, particularly for some of our patients because they're quite hard to get blood for. So there's now, the Spectra Optia has a procedure called a depletion exchange, and it was based on a study by Sarod and his team. And I can't remember the name of the hospital he works from, so apologies for that. But basically using the idea of hemodiluting patients prior to starting their transfusion of red cells in an exchange procedure to improve the efficiency of the procedure and potentially to reduce the number of red cells that are required to achieve your targets. So a depletion exchange is a 2-stage procedure on the Optia. You can do this on other apheresis devices. It's just not an automatic calculation. You have to do all the math yourself. But on the Optia, it's a 2-stage procedure. So you start your initial procedure with a depletion. And what's happening at that point is that you're removing those autologous red cells into the waste bag, but you're replacing it with that same volume with a saline. So you're still maintaining the circulating volume in their blood. You're not dropping their blood volume down, but you are just using saline to start with. And there'll be a minimum hematocrit or percentage of red cells that you can drop to, which is safe. And I've got a little chart to talk about that later. The second part of the procedure is then to transfuse the patient back to where you want them to be. So you'll set the minimum hematocrit, you start off with your hematocrit that the patient's currently at, you enter what you want them to drop to, and then you enter where you want them to end up, which might be the same as their starting hematocrit, or it might be slightly higher if they're anemic, or even slightly lower if they have a reasonably high hematocrit to start with. And the aim of that is, again, is to increase the efficiency of the hemoglobin S reduction. And there's some evidence to support that it can maintain or at least partly reduce iron levels, but that really is dependent on the individual. So Sarod's, this is from the article that Sarod and his team published. And the guidelines are, so obviously if you've got someone who's very anemic, then you're not going to be able to do this isovolemic hemodilution. You just limit to how low you can drop their hemoglobin and so forth before you start causing them problems. So they recommend if it's the hematocrit's less than 23% that you don't do anything. But then if it's above that, then you can drop it a certain amount, and then you've got to sort of transfuse up to a certain level as well. And that largely is dependent on the number of units of blood that you have available. So you do have to do a little bit of math and a bit of calculation around this, or at least some entering into the machine these parameters to make sure that you're able to achieve the targets that you want to achieve. And the machine will not let you do it if you can't. So there's some safety features built in that help to control that as well. But it's a good guide to have if you've not done the procedure before, to know what is acceptable and what is safe. So there's lots of practicalities when it comes to a procedure like this, and a lot of these are similar for any kind of apheresis procedure, but and venous access is certainly one of them. I will move on to that in a minute. But there are practicalities for our patients as well. They need to be able to attend prior to the procedure for a cross-match. They come to the apheresis unit where we work to make sure that the correct tubes are taken and they're sent to the right lab. And that's generally a fairly flexible drop-in appointment, but we like to do it 1 or 2 days in advance to allow our transfusion lab time to get the blood ready and do the checks that they need, and also to make sure that the blood that we have is compatible for them. We do have blood on a schedule with the Australian Red Cross Lifeblood team, and they've been, cannot say enough about how good they are at providing blood for our very tricky patients. A lot of them have multiple antibodies from many years of being transfused or difficult phenotypes to find blood for. Unfortunately, our donor population is fairly ethnocentric, and unfortunately our patient population is not. Our patients sort of represent all the countries that you would expect to see patients with sickle cell, and this isn't really reflected in the Red Cross population. So some of our patients do have great difficulty getting blood because of those ethnic phenotypes that they have just not being represented in the donor population. So we do fairly vigorous phenotyping and cross-matching of all our units. We phenotype for not just ABO and Duffy and rhesus, but also Duffy, KID, MNS, again, to reduce the risk of alloimmunization in this population. In terms of the procedure, it takes a few hours, so they've got to be able to come, and unfortunately we don't have an after hours or a Saturday schedule. Our latest appointment is 4 o'clock in the afternoon, so that can be difficult for people who are working. And it takes approximately 2 hours by the time you get in for a 6-unit red cell exchange. So it's a big commitment if you're doing that every month or every 6 weeks from our patients. So venous access, it all hangs on the blood flow, like any procedure that requires apheresis. Patients do need to have peripheral veins large enough to tolerate these large bore needles, and not everyone does. We have about 6 patients who have an arteriovenous fistula, which is a surgical procedure that joins a vein and an artery in the arm together. And that creates a high flow blood vessel, native blood vessel, which can then be used for permanent access. And they're great because they're not needed in between times. There's no maintenance required. However, a lot of our patients are young and there's body image issues associated with all of that too. So that has to be considered. Not every patient will have suitable veins for this kind of surgery, so we get them to have a Doppler study done first, and then they're referred to the renal department for management of that. The other alternative is, these days, what we've sort of defaulted to now is a single needle power port, which is what the picture shows you. And we found this to be really effective port device. It's inserted, again, it's a relatively short surgical procedure. It's inserted under the skin, and usually just above the, just under the collarbone or just below the collarbone in the chest, and then the catheter is fed into the superior vena cava and goes down into the main blood vessels into the heart. And with a single needle one, we've found that you get much better flow rates. With the double lumen apheresis ports that we used before, we found the flow rate to be quite problematic sometimes, and we found much better success with this. It does allow us to now utilise the single needle procedure, which is available on the Optia Spectra as well, and that is a red cell exchange procedure just using one access. It really needs to be something, a high flow device. A peripheral access doesn't work so well in these single needle procedures, but for a port device like this, it makes the procedure time very comparable to a double needle procedure, which is fantastic. The other thing we like about this port is that you access it with a 18 or 16 gauge cannula, so you can actually leave that cannula in situ if the patient's in hospital having IV therapy for a short time, and that helps to reduce stress on their peripheral access as well. With anyone who's having a port, though, we like to use an oral anticoagulant therapy for them, a very low dose of rivaroxaban or apixaban or one of those medications to help reduce potential for thrombus, which can arise from these mechanical devices. And with a prothrombotic condition like sickle cell, it's really important that we protect our patients from that. So there are some complications with red cell exchange. I mean, all procedures have their issues, I guess. Generally, it's a pretty well tolerated process. One of the biggest problems that we find for our smaller female patients is citrate toxicity, and that is arising from a transient hypocalcemia, which is caused from the citrate anticoagulant, and it causes a drop in their ionized calcium, which then goes on to cause various symptoms such as tingling around the lips and the face, which we call perioral paresthesia. They can get chills and drop in blood pressure. if it's not treated, it can progress to things like muscle cramps, and really severe citrate toxicity can result in prolonged QT interval in the heart rhythm and lead to heart arrhythmia. That's extremely unlikely, but it's a possibility. So some patients require calcium supplementation, and we often just give them an oral fizzy calcium Sandoz or something like that to help with that. But some of our patients require intravenous infusions as well. We have a special protocol for calcium replacement and apheresis. Iron overload or iron deficiency can occur depending on our patients. So we do regular monitoring of their iron levels, and they may require either supplementation therapy if they're deficient, such as iron infusions, or iron chelation if they have iron overload, in addition to having a depletion exchange. And of course, within the venous access, there are always potential issues. Bruising, repeated venipuncture for people with poor access can be stressful and painful, and infection can occur. With central line access, such as ports, and there is always a risk of bloodstream infection as well, which thankfully we don't come across, but nurses are very expert at accessing these devices in an aseptic technique. It's always a risk though. And transfusion being the major component of this process, then you've got the complications associated with blood transfusion. Alloimmunization to donor red cell antigens can be a big problem. Less so now that we have universal leukodepletion, but we do phenotype our blood cross-match very closely to prevent further alloimmunization. When you're removing or replacing blood, you can either take too much and it can cause a hypovolemic situation, which can then lead to fainting, or you can give them too much blood and then you've got increased viscosity, which is called hypovolemia, which increases the risk of sickling, and then you can also get conditions such as transfusion-associated circulatory overload. Not as much an issue in red cell exchange because you are returning or replacing blood in an even manner to maintain an isovolemic state, but it's, you know, if there's a problem with the procedure, for example, you could potentially end up with these situations. Happily, even more uncommon are immune-mediated hemolysis reactions, which can occur. Patients can get a delayed hemolytic transfusion reaction up to 3 to 4 weeks post-transfusion, and they might include symptoms such as fever and jaundice, abdominal pain, dark urine, and a reduce in their hemoglobin. I don't know whether, because often it's, you know, whether this is underreported, we don't have a great deal of experience with this because most of our patients don't seem to get it, but it may be just that it's such a benign condition that there's not really much else that happens that it's not reported. Much more severe, of course, is a hyperhemolytic transfusion reaction, which thankfully is fairly rare. But that is when you're getting destruction of donor and recipient red cells, which can result in severe anemia and reticulocytopenia, which reduces the patient's ability to make their own red cells. This is clearly a medical emergency, and it could occur at any time post a transfusion. If your patient comes in with a lower hemoglobin than when they went home, this is, and it's within a relatively short time of transfusion, this is something to really give serious consideration to. And of course, if you ever think there's been a transfusion reaction, then you need to do the normal transfusion reaction workup, checking for development of antibodies and hemolysis and so forth. So the benefits are largely, I jumped ahead, sorry, are very positive though. So despite the inconvenience of having to attend every 4 to 6 weeks for a couple of hours and having to come in for your cross match, our attendance adherence is pretty good. So this, I think, is testament to how the patients feel after their procedure and the fact that they know that this keeps them well and able to continue doing what they like to do best, which is live their lives. And they report positive benefits to their lives, including reduced number of crises. So some of our patients have been on the program have not had a crisis requiring hospital admission since they've been on exchange, which is really great to hear. They're able to resume activities normally not available to them, such as going for a swim, and they report increased energy levels. 70% of our patients are able to work or study either part-time or full-time, which is really great. And we've had 10 patients out of 11 who've had successful pregnancies, including one young girl who had twins. So that's awesome. Unfortunately, one patient did have lost the baby due to a placental abruption, which was unfortunate. But our pregnant patients do really well on exchange, and it's great to see. And the other benefit is that you have a regular engagement with your patients. So you're seeing them every month. You're able to develop that therapeutic relationship, which is really important in patients with chronic disease. And they have access to medical support as well when they come in, because there are doctors around. If they have any problems, we can always get someone in to come and review them. So having that close contact with patients is really great. So just to conclude, it is a really well tolerated therapy, despite the listed complications. They're generally pretty mild and easily managed. It does treat and prevent both acute and chronic complications of sickle cell disease. It is effective at reducing admission rates for our acute sickle-related events, and it can be effective also in reducing iron overload and or maintaining a neutral iron status, which is beneficial because that also creates its own health problems. And then just to finish up, this is the new Spectra Optia, which is a nice little tidy machine. It does everything for you. This is how we used to have to do it with our old Baxter CS3000 machine, where we had the blood being measured on a weight scale. We had to measure the hematocrit of the blood coming out of the centrifuge and make sure that we were transfusing the blood back through this system here at appropriate speed. And you've got a blood warmer attached on, so you had all these additional add-ons, and there was quite a lot of work involved in calculating the procedure. It was a complicated process. These days it's so much more simple and a really effective, nice procedure that we can provide for our patients if they need it. So thank you so much. I hope you have found that useful, and yeah, any questions?
Hi, Claire. Thank you for that. We have a couple of questions, but I can see we've come to the time for the session. So Agnes, is it okay for us to spend some extra 5 minutes just to answer the questions? Okay, great, thanks. Okay, so the first one is around how often should a patient do an exchange?
So that's really much an individual response that you need to look at the patient. So we generally start all our patients on 4 weekly, because that generally gets their sickle levels down pretty quickly. They're coming in with an untreated sickle cell level of say 80% of sickle blood, then we want to get them down to 30%. So we run a reasonably stringent 4 weekly schedule until they get down to those levels, and then we start stretching them out. But it is very much an individual. And it's not always just about the numbers, it's also about how people feel. So some of our patients do really well on 6 weekly, but they just don't feel well. We get their numbers down on 6 weekly, but they just don't get the benefit. They'd rather come 5 weekly. And we will decrease our intervals. At wintertime, we tend to decrease intervals because patients are more likely to become unwell and sick. And obviously, we know infection is a trigger for crises. So it's very much an individual procedure. You need to tailor it to that person and what works for them. It also depends on how much blood you're giving as well, I think, too. We use 6 units. Some units will use more blood and less often. So.
Okay, cool. I have 2 questions around hemoglobin or hematocrit. I'm probably not pronouncing this correctly.
Hematocrit, yeah.
Yes, hematocrit. So the first one is, so which should be considered for transfusion? Hemoglobin or hematocrit, and which should be given importance for transfusion?
Okay, so for a simple transfusion, I think you'd be looking at hemoglobin, to be honest. If someone's got a hemoglobin of 60, then you're going to just give them a transfusion or 2 or 3 units to bring their hemoglobin up. For an apheresis procedure, because the machine controls the way the procedure works by the hematocrit, that's the important feature in that particular situation. The hematocrit controls the plasma pump, which basically controls the interface between the plasma and the red cell layer, and that ensures that we're collecting red cells into the bag and nothing else. So that's why that's important. But if you're thinking about transfusing someone, you'd go by their hemoglobin for sure.
Great. And if you have experienced a delayed I'm not pronouncing this right, hemolytic, is it hemolytic?
Hemolytic, yeah.
Yeah, to transfusion, even though the blood type was very closely matched, can you consider blood transfusion in the future?
Yeah, you can. I mean, the thing is, these are reactions not to the ABO blood group or the main rhesus blood antigens. They're usually for lesser antigens. So we do quite extended phenotyping of our blood to to make sure that we give the blood as closely matched for some of the minor ones that can cause these delayed reactions, such as Duffy and KID antigens. That helps to prevent it, but it can still happen. I guess you just need to be aware. If you can identify the antigen, then you can avoid it for future transfusions, but sometimes these antibody levels aren't very high and you can't always pick them up. So I think if you're getting a patient that's had a delayed hemolytic transfusion reaction and you aren't able to establish the cause, then I would be cautious about proceeding. But you know, obviously if they had another one, then doing follow-up testing and also liaising with the transfusion specialists in your hospital about the best way to proceed for these patients. I think there are some patients you probably just wouldn't be able to continue with, but I would imagine the majority would be okay, providing it didn't reoccur. Yeah.
All right, great. And one final one. I think there might still be some questions later that you can have interactions with on Woover. But this one is, why do patients still experience iron overload when they are on red cell exchange?
Yeah, so I know there's the two sides of it. You get the ones that are iron overload and the ones that are iron deficient. So we have both patients, you know, both sets in our patient group. Iron overload occurs because generally patients coming in, they are anemic. Their hemoglobin is maybe 80 before they start the procedure, and you want to bring them up to about 100 at the end of the procedure, just to improve their, you know, general well-being and quality of life and, you know, energy levels. So even though you're not transfusing a lot of extra blood, they are over time getting a small increment in the amount of blood that they receive, and blood does have a lot of iron in it. A unit of blood will carry about 200 milligrams of iron, which is quite a lot. So yeah, if you're transfusing your patients up because they're quite anemic, then over time they're going to get iron overloaded. And of course you can't necessarily deplete the ones that are very anemic because they won't tolerate it. So yeah, that's an issue. So the best way to manage that is with iron chelation therapy as well. So we do have some patients who, even though they're on red cell exchange, still require iron chelation, and we monitor those levels very closely. In the same way that some of our patients are iron deficient, because their hemoglobins are quite high when they come in, and we want to kind of keep them within the sort of the recommended sort of 36% or less hematocrit level. So over time they can actually lose iron out of their with their procedure. So we do sometimes give iron infusions to those patients. So it's a balancing act for each individual patient.
Great, thanks, Claire. Agnes?
Yes, thank you so much, Claire. I just wanted to come in to say thank you so much for, you know, being with us and presenting for us. Very educational session. We have a lot of our members who are on either a red cell exchange or blood transfusions, and it's just good to know, to understand the process. So thank you so much for answering our questions. If we get more, we'll email them to you. And
happy to. Thank you.
Just, you know, anyone who's watching right now, we're asking for blood donors, especially in the minority ethnicities, because we know you have some of the patients that you find, you know, I heard that you sometimes have to get blood from overseas or interstate. So we do encourage people to donate blood. So again, thank you so much for joining us.
It's always a challenge.
Thank you so much for joining us on a Saturday and supporting Australian sickle cell advocates from the beginning.
It's a pleasure, Agnes. Thank you so much.
Okay. Thank you so much, everyone.